Okay, good afternoon, everyone. We'll go ahead and get started. Thank you for coming to Medicine Grand Rounds today. A few upcoming announcements. First, next week, we're excited to welcome another one of our own speakers, Dr. Sapna Patel from the Division of Medical Oncology, who will be presenting a talk entitled The Melanoma Remix, Neoadjuvant Beats and Cellular Hooks. I'm certainly looking forward to understanding that when I hear her talk next week. Please also note there's to be no grand rounds on Wednesday, November the 25th due to the Thanksgiving holidays. I hope everyone has a wonderful holiday, but we will talk about that next week as well. And then when you return in December, it'll be my turn to give grand rounds with the State of the Department address. And it's been quite a year, and I'll have several reflections, but also updates on where we are and where we're going. So hope to see you there. So I'd like to now introduce our speaker today, and it is truly a pleasure for me to introduce Dr. Cecilia Wang, who is a professor of medicine, but also assistant vice chancellor for clinical research operations on campus. Dr. Wang earned her undergraduate degree in chemistry with distinction from Pomona College, her MD with distinction in research from the University of Rochester School of Medicine. She completed her internal medicine residency and then served as chief resident at the University of Utah, followed by fellowship training in endocrine metabolism and diabetes here at the University of Colorado. And we've been lucky to have her here ever since. Her research centers on inpatient and outpatient glucose management, advanced diabetes technologies, and improving outcomes in vulnerable patients, including those with renal transplants and rural communities. For those of you who have ever used the hyperglycemia service, that is the service that Dr. Wang founded and currently oversees as well. She has led or contributed to numerous clinical trials, including the TIGHT study on continuous glucose monitoring in hospitalized patients, as well as the Victor pilot program that's focused on diabetes care in underserved areas. I could spend a long time telling you about Dr. Wang's accolades, so I'll tell you just about a few. She's received the Distinguished Research Award and the Charles D. Kochakian Award in Endocrinology. She's a senior fellow in the Academy of Medical Educators and a fellow of both the American College of Physicians and the American Association of Clinical Endocrinology. She currently also serves as vice chair of the American College of Diabetology. Truly, we're in for a treat today. Please join me in welcoming Dr. Cecilia Wang for her presentation entitled Advanced Diabetes Technology Beyond Type 1 Diabetes. Dr. Wang.
For that kind introduction. I don't know, can everyone hear me in the back? Okay, awesome. Thank you for that introduction, Vineet. So I wonder, let's see, let me advance the slide. So I can't talk about advanced diabetes technologies, CGM, automated insulin delivery systems without gratitude and thanks to the inpatient glucose management team, which I've been fortunate to direct for the past 11 years. And I think many of you know that I stepped down last month and then passed the baton on to Stacy Segelke, who is fantastic. And I did also want to mention that Boris Drasman was the person who established the team back in 2008. I also wanted to thank the Endocrine and Diabetes Clinic. Without our diabetes educators, there's no way we could get any of this done. So here's the outline. So I'll talk a bit about glucose monitoring, and then I'll focus on continuous glucose monitoring as well as automated insulin delivery system. I'll kind of explain why it's been so important for type 1 diabetes, but then also move on to the use of these advanced diabetes technologies in the hospital. And then CGM and AID for type 2 diabetes, and then beyond diabetes. So the last part, I wanted to give you just a few tips on reading a CGM report, because I think more and more of you will be seeing these. So first I wanted to start with a case. So this is a 67-year-old woman who was referred for diabetes management in the setting of CKD. She doesn't check her finger sticks, and she'd much rather use continuous glucose monitoring. So she's wondering if that's appropriate for her. So she's had type 2 for 11 years. She also has a history of hypertension, renal cell carcinoma, so she's had a nephrectomy, and hypothyroidism. She's overweight. She's on insulin. She's on a sulfonylurea. She's on a DPP-4 inhibitor and a number of other medications. And you can see that on exam, her exam is pretty unremarkable. Her A1C is 8.2%. She's got decreased GFR. And she already has albuminuria grade 2 with a UACR of 132. And the question is, would CGM or automated insulin delivery be beneficial for her? So diabetes technologies have been advancing rapidly. So this is a slide from March of 2024 when the FDA approved the first over-the-counter or direct-to-consumer continuous glucose monitoring. This was the Stelo, and this was approved for adults with diabetes not on insulin and who don't have problematic hypoglycemia, because this form of over-the-counter or direct-to-consumer continuous glucose monitoring doesn't have alerts, doesn't have alarms, and you can get them without prescription. So 3 months later, the FDA cleared 2 more over-the-counter glucose monitors. And I just wanted to mention that just a couple of months ago, the FDA approved something that was minimally invasive. And so this isn't available yet, but this is a glucose sensor that uses a microneedle sensor array and doesn't give you glucose values. So it just gives you glucoses either above the range, so that's yellow, or within the range, blue. And what I don't know is whether it has any trends or any other information, but more to come on that. So I also wanted to, as I am talking about all these technologies, I also wanted to talk about prevention. So one of the interesting things I found over the past years since I've finished my residency is that every single estimate I've seen for the prevalence of diabetes, even though the estimates seem overblown, they've been underestimates. And so this prevalence of diabetes has just risen so much over the past few decades. And so here's something from the Diabetes Atlas, the most recent edition, that shows the amount of kind of the prevalence of diabetes percent that is predicted to continue to increase over time. And just November 14th was World Diabetes Day. This month is Diabetes Awareness Month. So here's kind of a qualitative view of why I think glucose monitoring is important. So it's qualitative because it's just a risk continuum for hypoglycemia and microvascular complications. These are huge reasons that we would want to be monitoring glucose. One is to reduce the risk of hypoglycemia with hypoglycemic therapies. And then the other is to reduce the risk of microvascular complications. And so I think the lowest risk is people with stage 2 type 1 diabetes. So who here has ever heard of stage 2 type 1? I see just a handful of people. So stage 2 type 1, there's been a huge focus the last few years on pre-diabetes that's actually pre-type 1 diabetes, because there's a new therapy to slow the risk of progression to type 1 diabetes. So we need to be able to identify those individuals with pre-type 1 diabetes, and not, when you see a patient with pre-diabetes, not just think of type 2, they might have type 1. So people with stage 2 type 1 diabetes, which is a form of pre-diabetes, probably have pretty low risk for hypoglycemia because they're still making some insulin. And people with pre-type 2 diabetes also are at low risk of hypoglycemia. People with early type 2, probably towards that end of the continuum as well. And then the people who are at the highest risk for hypoglycemia are those with, still type 1, but in that honeymoon period, people with type 1 diabetes, and then also people with type 2 in the more advanced stages. And so the individuals with type 1, as you know, have lost a lot of their beneficial counter-regulatory hormone responses, so that's why they're at higher risk for hypoglycemia. So it would be great to be able to monitor their glucoses. So the other reason to monitor glucoses is to lower the risk of microvascular complications that come with prolonged hyperglycemia. And so the people who are at the lowest risk for microvascular complications, again, are those people with prediabetes that's type 1 diabetes, so stage 2 type 1 diabetes. And if you haven't really heard of this, I encourage you to learn more. There's a whole talk in the classification of diabetes. Pre-type 2, also on that lower end of the risk continuum for microvascular complications, although I do want to emphasize that when you see someone with prediabetes, they're already at double the risk for macrovascular complications, and some, when they first get diagnosed, already have some of the microvascular complications. And so prevention is so important. People with early type 2 are also at lower risk for microvascular complications. And then I kind of have this big, wide continuum for people with type 1, because it really depends on how well you're managing your hyperglycemia. And then individuals with advanced type 2, they're still at lower risk for these microvascular complications when you compare them to individuals with type 1. So about 100% of individuals with type 1 need to be on insulin. That is not quite 100% because there are some individuals with type 1 still in that honeymoon period that there are a lot that we struggle with in our endocrine and diabetes clinic that don't quite require, kind of usual doses of insulin. So that's why that's not 100%. But about a quarter of individuals with type 2 are on insulin therapy. And unfortunately, insulin, when we use it as a therapy, has a very narrow therapeutic window. And so when we're trying to get towards normal or euglycemia, that increases the risk for hypoglycemia. So that need to monitor glucose control was recognized pretty early on after the initial purification and isolation of insulin back in 1921. But those efforts really focused on measuring glucose in the urine. This was until 1969 when someone named Anton Clemens invented the first glucose meter. It was called the Ames reflectance meter, and it used reflectance photometry. And so the thing is that it told you whether your glucose was low, medium, or high. And unfortunately, it read high at the low ranges and low at the high ranges. So it was pretty inaccurate. And it had to be calibrated every single time, and it wasn't very portable. It was 1.2 kilograms, and it was incredibly expensive, so not affordable. So it cost $650 in 1969 dollars, but that's equivalent to about $3,500 now. So it really wasn't very practical. And then the other problem is that the Ames reflectance meter was actually marketed towards physicians, and so patients didn't have access to this. So here's kind of a next version of this, the Ames iTone that was made developed in conjunction with a Japanese company. So as I was preparing for this talk, I learned a lot about glucose monitoring. And one of the things I learned was a really neat story about Richard Bernstein. So he's the reason that we actually recommend self-monitoring of blood glucose. So here's a picture of him. This is actually from the Wall Street Journal from this past May. He just passed away this past May, but lived to the ripe old age of 90. And he was diagnosed with type 1 diabetes when he was 12 years old. So at that time, the way he would manage this was once a day insulin injections, a low carb diet, and then seeing his doc once a month. And so in his 30s, he started to develop frozen shoulder. He had repeated episodes of hypoglycemia. He couldn't see at night. And he was really worried about being able to live long enough to see his kids grow up. And so he heard about this thing, the Ames, or actually he heard about this Ames reflectance meter and wanted to get a hold of it. But because you had to be a physician to get it, he asked his wife to get it. His wife was a psychiatrist. So he got a hold of this, started monitoring his glucose, and then was able to start adjusting his insulin doses to try to prevent hypoglycemia. That was really the main goal, to try to prevent it and then obviously try to prevent complications as well. So then he thought, gosh, this is really working great. I need to get this to more people. And he lobbied with Ames. He tried to get different professional organizations and journals to publish his findings, and no one would do it. So there was a lot of resistance. And so what he ended up deciding to do is going to medical school. So he went to medical school at the age of 45, and he finished medical school, did a residency in internal medicine, and then did an endocrine fellowship. Then after that, he opened up a diabetes clinic and started teaching his patients how to do self-monitoring of blood glucose. So really incredible story. And I have to say, this is an example of advocacy by incredibly strong advocacy by our type 1 diabetes community and our diabetes community in general. So it was that self-monitoring of blood glucose that made the DCCT and subsequent glucose control trials possible. So without it, there's no way we could have done these things. And before the DCCT, there was really no great evidence that controlling glucose was going to make a difference. And so just a reminder that we have now the DCCT as well as the UKPDS. The DCCT was actually enrolling individuals with type 1 diabetes, either with no retinopathy or mild retinopathy. So it's mainly a retinopathy trial. So the goal was to try to show that if you had intensive glucose control, that you could reduce the risk of retinopathy. And so there were 1,441 individuals enrolled between 83 and 93. And so this is really in the early times of that self-monitoring. and follow-up for 6.5 years. And what it showed in that initial DCC trial is that intensive glucose control decreased your risk of retinopathy by a huge amount, and then also your risk of albuminuria and your risk of neuropathy. And of course, we have a follow-up study, the EDIC study, that's had 10, 20, 30 years of follow-up, and the most recent follow-up was that 30-year follow-up that showed a decreased risk of major adverse cardiovascular events by 32%. The UK PDS was type 2 diabetes patients, and that was done between 1977 and 1991 and enrolled 4,200 individuals. And I just pulled out, it was a very complicated trial and divided individuals between those on metformin versus those on sulfonylurea and insulin. But I just pulled out a couple of important things because I think that there's a lot of emphasis on decreasing macrovascular disease, which I think is incredibly important because that's what our patients die of. But I think just remember that the reason that we try to control glucose is that when people develop microvascular complications, their quality of life goes downhill, and people, their health span is incredibly short, and their lifespan as well. So here I'm showing lifespan, so all-cause mortality. So in the metformin arm, the absolute risk reduction in the intensive control arm was 7.2%. I think this is better than anything I've ever seen in any other trial. And in the sulfonylurea insulin arm, that absolute risk reduction was 3.5%. And then for any microvascular disease, that risk was also reduced. So just wanted to emphasize that we kind of forget about these numbers when we talk so much about heart disease and heart failure, which is so important, but I just want to bring home kind of why we care about glucose. So what does the glucose monitoring look like? So back in the 1990s, we had some old-fashioned glucometers, and then those got a little more advanced. So these are the ones that you might see your patients using now. But the problem is that all of them require finger sticks, and finger sticks are incredibly painful. And as an endocrine fellow, I got to wear all sorts of things, insulin pumps, with saline in them, continuous glucose monitors, the gluco watch, and I had to check my finger sticks. And I was only able to check my finger sticks like twice, like it was so painful. And so I think that asking our patients to do this, we really have to have great reasons to do it. We have to look at the data. We have to recommend it in a very, we have to recommend it carefully, I guess, and use the data. But I think all of that was an impetus to try to think of other ways. So back in 1999 was when the first continuous glucose monitoring system was approved. So at that time, it was blinded, so people couldn't actually look at their information. They had to go in to the clinic, get the information downloaded to look at this retrospectively, and it was only for 3 days, or they called it 72 hours at that time. So over the past 20 years or so, we've had lots and lots of improvements in continuous glucose monitoring. 7-day real-time, 14-day intermittently scanned, 10-day real-time, 14-day, and then now we have the 15-day real-time continuous glucose monitors. And I don't know if people are aware that back in September, there was the 365-day implanted CGM. So lots and lots of advances in technology. So how do they work? So this is just a quick view of that. So one thing to remember is that people have this plastic filament that's inserted with a needle, and it's inserted into the interstitial fluid space. There's kind of sampling intermittently of interstitial fluid. So what you're really looking at is interstitial fluid glucose, not blood glucose. And how does all of that work? So basically, the glucose in that interstitial fluid combined with water and then catalyzed by glucose oxidase, you end up getting some gluconolactone that is rapidly converted over to gluconic acid. And then that combined with hydrogen peroxide ends up creating a current. And then that's what's picked up. And then this turns into a number that we see. So the current CGM systems either sample from that interstitial fluid every minute or every 5 minutes. And again, it's interstitial fluid. So what we see when we look at the readout is the glucose value. We see the trend arrow. Is your glucose going up? Is it staying the same? Is it going down? And then is it doing it severely so? We see glucose curves, so you can look at your glucose trends over between an hour to the past 24 hours. And then importantly, you can look at the percent time in range and various ranges. And you can look at the average glucose by the day of the week. There might be certain days that your glucose is higher or lower, and then your average glucose over time. And lastly, the readout can be either a separate reader, or it can be a smartphone, or now some versions, you can actually see it on your Apple Watch. So what metrics? So you can imagine that there's a lot of data that comes out of every minute or every 5-minute sampling of glucose. Like, how do you make sense of that, and how do you standardize that? So there are several international consensus conferences that were convened, and the most recent one in 2019 was probably the most pivotal. And so it came up with standardized CGM metrics and then also targets. And so the way that we think about our CGM data are that the optimal glucose time in range is called time in range between 70 and 180 milligrams per deciliter. There's time below range, level 1 and level 2. So level 1 is between 54 and 69. Level 2 kind of correlates with level 2 hypoglycemia, which is less than 54. And then we have 2 intervals for time above range, either between 181 and 250 or greater than 250. And so it turns out that about a 10% increase in your time in range correlates with an approximate A1C reduction of about 0.5%. And then the other thing is that for each 10% reduction in time in range, that hazard ratio, when people actually retrospectively looked at the DCCT data, found that there's a increased hazard ratio for retinopathy of 64%. So these numbers really matter. And so what numbers are we looking at? So for the time in range, we're really targeting greater than about 70% in most individuals with type 1 or type 2. And then those who are older or at high hypoglycemia risk, what we're targeting is about greater than 50% at least. And so this graphic kind of gives some of the other goals for time above range, time below range, because we want to get to that good time in range with very little hypoglycemia. So I think it's safe to say that CGM has revolutionized the self-management of type 1 diabetes. People have less hypoglycemia, both overall, nocturnal, and then also severe hypoglycemia. But this is done with better glucose control. And then there are actually better patient-reported outcomes and clinical outcomes. And so people are so much happier because they don't have to be doing all those finger sticks I was talking about. So I wanted to move on quickly to automated insulin delivery. And so why do we care about insulin doses? As everyone knows in this room, medication adherence is incredibly difficult, even for ourselves. Trying to remember to take something every day, and then now imagine trying to take something multiple times a day is incredibly difficult, and then to take the right doses. So here's a small study that just looks at the impact of a single missed basal insulin dose in a 14-day period. And I think that I would say that this is actually probably the smaller percentage of my patients on multiple daily injections. Most of my patients on multiple daily injections miss a lot more than just a single dose of insulin per 2-week period. So in this study, this is actually using smart pens. So these pens can tell you when and how much your patients have been injecting their basal and their bolus insulin. So it's really helpful. And so in this particular study, just looking at the number of missed doses, the estimate was that the probability of someone missing a single basal insulin dose during a 14-day period was about 22%, which seems low to me. But for every single missed basal injection, time in range decreased by about 2.6%, and the mean glucose increased by about 8 milligrams per deciliter. So just a huge impact of a single missed dose. So wouldn't it be great if people didn't have to remember to take their insulin? So that was the idea behind continuous subcutaneous insulin infusion devices. So if you could wear something, had a reservoir of insulin, and then continuously infuse that insulin, wouldn't that be great? And so these were actually released first in the 1960s. And so the different components are that insulin reservoir, delivery, through a subcutaneous catheter, and then some kind of controller. So here are some examples. And then most of the versions have tubing, but here's a version without on the right. And so what does it do? So remember that these have rapid-acting insulin in them. So it's continuous subcutaneous infusion of rapid-acting insulin. And then these user-programmed boluses for meals and to correct high blood sugars. So you can do that in different ways, either using a calculator that's on the machine, or it could be fixed doses that you give the patient, or there's a newest system that allows you to not do any carb counting, and then you have these personalized meal doses for breakfast, lunch, and dinner. So I'm not going to spend much time on the insulin pumps because things have progressed so much past that now, and this is automated insulin dosing. So this is basically a system where you're taking that continuous glucose monitoring data and then giving that to an insulin pump and then delivering that insulin. So this has had a lot of different names. A hybrid closed loop system, I think, is the most accurate. That was the original term. And the first one was approved almost 10 years ago in 2016. So it's been called a number of these other names, closed loop, bionic, and I think those are all pretty inaccurate. And so it's basically taking that continuous glucose sensor information, going through a control algorithm, and then delivering this information to the insulin pump. And there are automatic basal rate adjustments, and I didn't include a curve of what that can look like. One of the examples of why insulin delivery using these systems has taught us so much is that when you give single dose of basal insulin, you're giving a single dose, and it's the same all day. You don't really have a lot of control over how much is being delivered kind of within that 24-hour period. When you have an insulin pump, it's really great because you can program different basal rates at different times of the day. So for example, if you know that someone has dawn phenomenon, you can program a higher rate, for example, between 2 and 4 in the morning or 2 and 6 in the morning, or lower rates when someone is always exercising. So the thing is that we found out after these automated insulin delivery systems were developed that basal rate that these AIDs deliver can vary by 4 to 10-fold. And we can't do that with injections, and we can't really do that real time with our insulin pumps. And so these pumps can also auto-suspend. So if it starts to detect that your glucoses are dropping, it can suspend basal insulin delivery. And then when it sees that your glucoses are going high, it can give you some extra boluses. And there are some low glucose and high glucose predictions. And then the most recent, this is another example of kind of patient advocacy. And so I had to put this in here. And this is a control algorithm that actually came about and was FDA approved from patient data. So patients with type 1 diabetes really, really wanted to, this is kind of that DIY movement. And so that algorithm is called Tide Pull Loop. And then we now actually have a pump that can use that control algorithm. So just a quick word about control algorithms. There are really 2 different kinds that are used in these closed loop systems, and this is an incredibly important component. So this is why I wanted to spend a slide on this, is that we think about the CGMs and we think about the pumps, but really this is probably the most important thing. So model predictive control is one of the 2 systems that's used in these different closed loop systems, and this has really become the method of choice. And so this has kind of progressed over the past decade or 2. And it's much more individualized, allows for prediction, and it can learn the patient. And so there's another control algorithm that's called PID that we really don't use anymore. So I also wanted to highlight the work that's been done to develop, this kind of artificial pancreas. So there's a really great series of articles that goes over this history that was published recently. And I wanted to show you a couple of things related to this and highlight a couple of things. So this year marks the 75th anniversary of the NIDDK. And it was really through the NIDDK and then the special diabetes program under the NIDDK that made all of this possible. So 20 years ago, no one thought that an artificial pancreas was really possible and that it was even worth working on. And now it's become the standard of care for type 1 diabetes. And so you can see on the lower left, here's kind of a pretty standard, this is kind of what we see for all of these randomized control trials of automated insulin delivery systems. In blue is kind of usual care. And then in orange, you can see the improvement in glycemia with no hypoglycemia on these automated insulin delivery systems. So just incredible. So you can see why automated insulin delivery has revolutionized the management of type 1 diabetes. And so what our patients tell us is that they can sleep now. They don't wake up overnight worried about hypoglycemia. And they can kind of live their lives and not be thinking about their diabetes 24 hours a day, every minute of the day. The other thing I think is that with automated insulin delivery systems, parents have been able to breathe a little easier with their kids with diabetes, toddlers with diabetes, and then also family members feel better about their family members with type 1. So what do the guidelines say? What does the American Diabetes Association say about this? Who should be offered this? So they were actually quite broad. So type 1 diabetes, of course, but then also other types of insulin deficient diabetes. And then the other thing is that insulin pump therapy, preferably with CGM, should be offered to youth and adults on multiple daily injections with, and this is individuals with type 2. So very, very broad recommendation. And so I don't want to sugarcoat kind of how great those are, because there are a ton of limitations. So this is one of 2 slides of the different limitations of AID. And so one of the things to keep in mind is that when we're delivering the insulin subcutaneously, it's still not physiologic, because our insulin, when it's being delivered by our pancreas, goes into the portal system or the portal circulation. So this is all still not physiologic. So we're still not there yet. And there are a number of different limitations of AIDs: physiologic, behavioral. We still depend on patients to bolus their insulin. There's a lot of troubleshooting that needs to still be done. And then there's a ton of technical issues. So all of our patients using advanced diabetes technologies, you'll hear a lot about the problems that they're having with sensor connectivity, with bad sensors, with, we in the past have always had kinked tubing, and just a number of different problems. And it doesn't take very long, because these systems are infusing rapid acting insulin. It really doesn't take very long, just a few hours, for people to go into diabetic ketoacidosis. So what are the essential points for clinical practice for the non-specialist? I would say that AID, we now see that it increases time and range without an increase, and sometimes with a decrease in hypoglycemia. It should really be considered for all populations with type 1. And the currently available systems still require some input from the user. And I'm going to spend a little bit of time at the very end on the different disparities. And part of it has to do with, a lot of it has to do with access, but then a lot of it we can control. So I'll talk about that at the end. And so now a little bit about CGM and AID in the hospital. So before the COVID pandemic, there wasn't really a lot of work on CGM in the hospital setting. And so there wasn't a ton of interest. So I was part of a roundtable that met back in 2013 of people who were interested in trying to increase the use of both the research that was done, as well as the use of continuous glucose monitoring in the hospital. But we couldn't get anyone interested at that time. And then the COVID pandemic happened. And so at that time, the FDA actually granted what they called non-objection to the use of CGM in the hospital setting. So at first, it's restricted, but they were going to not object to the use. And so because of that, there was an explosion of research on the use of CGM in the hospital. And we got a lot more experience. And then the FDA actually granted breakthrough designation for one of the hospital systems, which we actually haven't heard too much about since then. And then there's the end of this public health emergency. So there's less work being done by the companies, we think, because of this. But right now, there's no continuous glucose monitoring system that's approved for use in the inpatient setting. And of course, AIDs rely on CGM. And so kind of by implication, AIDs are not really approved for use in the hospital setting. So what are the current issues that we're dealing with? FDA approval, accuracy is a huge one, so I'll talk about that a little bit. Trying to integrate those data into the EMR, and then troubleshooting all the different issues. And so we're constantly trying to troubleshoot connectivity and sensor issues. And then obviously we have, hospitals are incredibly complex environments. And so trying to incorporate this into that nursing and provider workflow is difficult. With the AIDs, I think a lot of providers and nurses are not familiar with AIDs. They can't tell the difference between when a pump is delivering or not delivering insulin, whether it's connected or not connected to a CGM. And knowing that you need to make sure that that reservoir insulin supply is adequate, trying to troubleshoot issues with a pump, trying to access the data, and then knowing how to review those data. And so the problem is that right now, most hospitals don't have a way to validate the continuous glucose monitoring data, so we don't know when it's accurate. So here's a study that we were involved in, and this is just a little bit of data to pull out here, looking at CGM accuracy. So we called it the tight ICU. This is focused on the G7, which is one of the most up-to-date sensors that we have available. And unfortunately, if you look on the right side, let me see if I can point to this. One of the standards that we look at is accuracy in glucometers as well as CGMs. And what you can see here, this 15-15 rule means 15% of the glucoses, the percent of glucoses that are within 15% of the blood glucose or if it's less than 100, then within 15 milligrams per deciliter. So that's a pretty wide, pretty low bar. And you can see that at the different glucose ranges, actually, it was not necessarily the greatest in the ICU with the G7 sensors. When you expand that to an even lower bar of 2020, this number increases, but I think that accuracy is still an issue with our continuous glucose monitors in the ICU setting. So what then we tried to do on the non-ICU setting is to try to see if CGMs could help with decreasing the risk of hypoglycemia and still getting us to tighter control. So this was kind of a next step after the NICE sugar trial, which, if you guys remember, made huge news back before, it was around 2008 or so, because the big news from that was when we tried to do intensive control in the ICU, then if it was too intensive, then people had more heart attacks. So that was kind of the bottom line. And so the problem is that we didn't know if that was happening because of that intensity of glucose control, or if it was happening because people were getting too much hypoglycemia. So one of the things we do know is that in the intensive arm of NICE sugar, there was a 14-fold higher rate of severe hypoglycemia. So we really couldn't rule out the fact that it was actually the hypoglycemia. And if we could get to tighter control without that hypoglycemia, would patients benefit? So that was kind of the genesis of this kind of pilot trial, which was called TIGHT RCT. And just and there are a number of units and individuals across the hospital who helped with this. So I really appreciate their help and their willingness for us to enroll patients into this trial. This was a multi-center effort. And what we ended up finding is that right now, we have an incredibly strong culture of anti-hypoglycemia in the hospital. So we couldn't get people to goal. That was one thing. I think the second thing, though, to not forget is that in the intensive group, we got people from a mean glucose of about 180 down to 185 to 170. In the standard group, it started out at 175, so it's a little bit better, but stayed at 175. So we did get people to better control, but we couldn't get them to this tight control target. We were trying to get people to 90 to 130, so maybe that's not realistic. So just a little bit of take home on the inpatient use. So right now, CGM is adjunctive in the hospital setting. We still require fingerstick blood glucoses, and there's a number of reasons for that. It shouldn't be used during glycemic emergencies, and then because those automated insulin delivery systems really require accurate CGM input, and accuracy is affected by so many different things, we really don't recommend AID without the guidance of a diabetes specialist. And so what we also found from the TIGHT RCT is that when you wear a CGM, just placing the CGM on a patient and then not being aggressive about titration and having aggressive titration protocols, we can't improve control that much. So what about the use of advanced diabetes technologies in type 2 diabetes? Because I think that the vast majority of the audience is taking care of patients more with type 2 maybe than type 1. And so this was one of the first trials looking at continuous glucose monitoring versus usual care in patients with type 2 diabetes getting multiple daily injections. And what it basically showed was better A1C, greater time in range, less hypoglycemia, or no difference in hypoglycemia. And so what about automated insulin delivery systems? So this was a meta-analysis of 7 randomized control trials published a couple of years ago. Compared to the control group, basically the automated insulin delivery system increased the time in range by about 6.5 hours in patients with type 2 diabetes. And some of that was overnight, some of that was during the day. It also shortened the time of glucoses above 180 by about 6.5 hours. And there was really no significant difference between the two groups in terms of overall daytime and nocturnal hypoglycemia. And so this was kind of an example of the most recently published automated insulin delivery trial in type 2 diabetes. And basically, there's a point I want to make about this, which is, so this is AID versus the prior regimen, which is basal bolus for most people, insulin pumps without CGM for some individuals, and everyone in this trial was on a CGM. And the primary outcome was the change in A1C. So there was an improvement in A1C on AID. There wasn't increased hypoglycemia, and you can kind of see the curves there. But one of the points I really wanted to make was there's a huge disparity in kind of who we think might be appropriate for these advanced diabetes technologies. And so what this group did was they actually broke it down by subgroup, and it didn't depend on the sex, the age, C-peptide level even, numeracy, whether the person was on basal bolus or pump, or if people had experience with CGM. And then lastly, I didn't include this on the slide, but the level of education. Everyone benefited from the automated insulin delivery. So what does the ADA recommend? So they recommend early initiation. Don't wait forever to start these technologies. And I wanted to mention that CGM, unfortunately, the accuracy is still an issue. So this is a small study where 23 individuals wore 3 different CGMs for 14 days. And so you can see that every line here, so the different colors are the different CGMs, and you can see huge differences in some people with the different CGMs, and these were all worn at the same time. So accuracy is still an issue, and we don't know when it's being inaccurate. So that's one of the problems. So what we tell patients is, if you have a reading that you don't quite understand, if you have a reading that's low or high, or if you're feeling a certain way, then you need to verify with finger sticks. So the summary is that the pros, we can decrease the number of finger sticks. People love CGM instead of having to do those finger sticks. When we have this data, we can look at the glucose trends. And then you can also have alarms to tell you when your glucose is trending down or trending up. And you can set those alarms, for example, at higher than 70 so that people can try to do some preventive measures for the hypoglycemia. And then you can look at your data over time and then better understand factors that are affecting your glucose. But there are a number of different cons. So I mentioned the interstitial fluid lag, there's sensor connectivity, smartphone compatibility, so not every smartphone connects with these CGMs, the cost, the access, the coverage, and then maybe some level of tech literacy. A huge problem is the skin reactions to the adhesives. So we spend a lot of time with some patients on their skin reactions and the difficulty they have wearing something 24 hours a day, and then the accuracy. But the standards for CGM right now are that individuals with diabetes on any type of insulin therapy should probably be on a CGM. And adults with type 2 diabetes treated with glucose-lowering medications other than insulin, maybe we should be thinking about it. And so I wanted to move to kind of switch gears and go beyond diabetes. So there's been a lot of interest in the use of CGM for prediabetes. And so why would we want to do this? So one is maybe we want to diagnose prediabetes earlier. Maybe it could be a tool for lifestyle change. So if you saw that your glucoses were increasing with certain activities or certain foods, you might do something differently. It could help you monitor your prevention efforts, including reversion to normal glycemia. And then also you might be able to monitor long-term prediabetes. And I have Salwa's picture here because she's one of our former endocrine fellows who's now on faculty at the VA. And she's published spearheaded a couple of publications that I'll show you here and on the next slide, looking at CGM and prediabetes. So at the bottom of the slide, you can see this is a 41-year-old individual with prediabetes. And this is kind of a typical CGM tracing for him. And on the weekends, unfortunately, he has a fair amount of hyperglycemic spikes. On the lower right, you can see that all of the non-postprandial glucoses are looking great. They're within that gray bar, but after certain meals, the glucoses spike. So could that be some form of prediabetes that we need to be aware of? And then what metrics should we be using? So should we be looking at a different target? So should it be 60 to 140 instead of 70 to 180? Should it be 54 to 140? And then what percent time in range? And then should we be looking at postprandial? So anyone who's ever worn a CGM and worried about prediabetes, you might see that your glucose increases with certain foods. I've worn a CGM various times over the past 5 years, and unfortunately, it's very stressful. And so anyway, and then the other question is, what measures of glycemic variability should we be thinking about? So here's kind of a sobering message from a recent study that shows that actually those CGM metrics, if you don't have diabetes, so they've all been studied for diabetes, not for people without diabetes and not for people with prediabetes. So there's really no association between A1C and your CGM metrics when you don't have diabetes. So this is something that I hope you can kind of let your patients know, especially when they get a hold of these over-the-counter monitors, and people who are able to get kind of, or pay out of pocket somehow for these monitors that give you a lot of glucose data, it doesn't really correlate with the A1C, so that's a problem. And so just a couple of quick steps on interpreting a CGM report. So this was kind of put together from that International Consensus Conference. So when we look at a report, what we're looking at is 14 days is the standard. We're looking at the time that person was wearing it. So it needs to be at least 70%, so that's adequate data. And then we're looking at the average glucose. So here it's 166. And then what's the time in range? So is it 70% or greater? For this person, it was 68%. This is one of my patients with type 2. And then is there any hypoglycemia? So that needs to be quite low. Threshold's 4%. 4% is probably too high, but for this person, it was 0%. And then how variable is the glucose? So the standard is less than 36%. For this person, it was 27%. And then we look at the 14 days crunched down into a single graph. That's what this average glucose or ambulatory glucose profile is. And what we see here is we look at that median line to see when people are going high and low. And then for him, his glucoses were higher between about 7 and 8 and 7 to 9 p.m. And then he had better control overnight. And then lastly, you can look at, on that same initial page that you get from your download, you can look at the daily reports for each day of the past 14 days. And here's where I can find hypoglycemic episodes. I can look for episodes of hyperglycemia. And so for this individual, there are a lot of hyperglycemic episodes after lunch or dinner. And then you can see this one spot where he kind of lost all sensory connectivity. And so is it because he's eating higher carb meals? Is he weight training? So he has lots more adrenaline kind of secretion. Is he missing bolus insulin? Is he bolusing late? And so right now, we have these major advances in diabetes technology, diabetes therapeutics, but unfortunately not everyone who needs them or who could benefit from them have access to the therapies. And so Ananta Adala and many other colleagues around the country and around the world have looked at access and tried to research this. And I think the bottom line is that I'm going to really just focus on the diabetes technology. There are things that we need to be thinking about, like area deprivation, marginalized identities, and public insurance, maybe increasing the risk that someone might not be offered diabetes technologies. But there are actually another number of upstream costs that maybe we can be advocating for. So one is lower cost. We should be working on our implicit bias. Coverage policies, perceived discrimination, social determinants of health, and stigma. And so what she's demonstrated, she's a pediatric endocrinologist at Stanford, is that when you offer these technologies to just about everybody, everybody benefits. And so I also wanted to highlight the work of Sean and Tamara Ozer in the family medicine department at our university. So they've done a lot of work on implementation of CGM in primary care. So this is just an example. They've put together a toolkit because I think one of the biggest questions is how do we do this? Because you put in a prescription for a CGM or something for your patient and then it gets denied. And so what do you do next? And so a lot of the time it's because the prescription should really have been filled out for a DME, so durable medical equipment instead of pharmacy benefit. And so there are all these different intricacies on how to do this. And so I think that there are some different steps, but there are lots of resources out there. And so one of these resources I wanted to highlight here is called diabeteswise.org. So there's a professional version of this website as well. And so you can, it's hard to remember all these different devices. And it's hard to keep up with them. So you can actually go to this website, see the different devices, including the over-the-counter ones. So when you have a question from a patient about the over-the-counter ones, that's on there. And I wanted to highlight, so you can choose, are you interested in affordability and access that you want to compare across the different CGMs? Are there certain limitations that the patient has, like vision, auditory, or dexterity? And then also the different patient considerations. Are they especially active? Are they interested in easy insulin dosing, et cetera? And then you can also look at coverage on this website. So I looked up Colorado for the Dexcom G7 and then type of insurance, and it just gives you a lot of updated information that's really useful. So it's a nice resource. So just a little bit of follow-up before I end. So that patient that I was telling you about, so I stopped her sitagliptin, I stopped her glimepiride, I saw that she had CKD, I started her on semaglutide, and then I was able to up-titrate that gradually over the next few months. And she was in clinic recently, and at the same time that I've been up titrating her GLP-1, semaglutide, which we have strong data from FLOW that this decreases the risk of CKD progression, and placed her on epagliflozin. Her A1C is well controlled at 6.9%. She's completely off the insulin, and her UACR has come down to 51. So I think the question when a patient like this comes in, it's not just, can I go from fingers, instead of doing finger sticks, should I, be started on a CGM? Of course, we need to also be looking at the overall regimen and trying to get people off insulin if we can, and trying to down titrate or eliminate the sulfonylureas for sure, and thinking about the other beneficial therapies. But if I hadn't been able to get her off the insulin, then I think a CGM would have been really helpful, especially in the setting of her CKD. So what's on the horizon? That 365-day implantable sensor is already available. I think we're going to be seeing improved accuracy, continuous ketone monitoring. Minimally invasive CGM was just released, the first version of that, and then non-invasive CGM. And so I wanted to show you what that looks like. So there's a lot of work being done on non-invasive CGM. So this is just a schematic of contact lenses that can measure your glucose. So this is just one of the many things that people are working on. And then maybe fully automated AIDs. And so just to recap, we went through lots of different topics over the past 45 minutes or so. And so just a few take-home points: to refer your patients with type 1 diabetes to a specialist, and then strongly consider CGM for all of your patients with type 2 if on at least one injection of insulin a day, or on sulfonylurea or a glinide. And then there are a lot of different considerations. And so really there are some things that need to be restructured to make this work in the clinic setting. And AID has recently been FDA approved for type 2 diabetes as well. So this is something that we should be considering for those individuals on basal bolus regimens. And so I'm not going to go through the step-by-step approach to CGM. I have some really useful references, so I hope that, and one of these actually goes through some more detailed step-by-step for CGM interpretation. And then, and I wanted to mention that we have an awesome endocrine fellowship. I think everyone knows about that, but I think many people don't know about our one-year diabetes fellowship that's really focused towards people who are doing primary care and want to specialize in diabetes. And so I wanted to highlight that this is available and we have a spot. We're not in the match. And then if you want to wear a CGM, we actually have a conference where we're going to have CGMs available for people who register and come to our meeting. And lastly, I wanted to acknowledge the endocrine division for their support over the years, initially Chip Ridgway, Ryan Haugen, and then now with our fantastic leadership with Dr. Goldner, and Boris Drasnin, who established the glucose management team and has been an amazing mentor, and then all of the different connections I've made through a group that he pulled together that he called the Pride Group, individuals in the Diabetes Fellowship, Sarit Polsky, Beth McLaughlin, all the CU faculty who have helped train our fellows. And then, of course, the endocrine clinic I mentioned. And then I wanted to also lastly mention the American College of Diabetology. So this is a nonprofit that I co-founded a few years ago to try to increase and expand the access for specialized training for individuals who are in primary care. And so we have given out, so we've developed a board exam for diabetology. We've given out $1.3 million in seed funding to establish new diabetes fellowships across the country. We've tripled the number of diabetes fellowships, and we're working on many other initiatives. And we've partnered with all the endocrine organizations and diabetes organizations to try to do all of this. So thank you so much for your attention.
Dr. Wang, thank you for a wonderful talk, and also thank you for your advocacy for this really important disease area. I'm going to open it up for questions, but I'm going to ask you one because you talked about this briefly. I just finished a week of service. I had a patient who was sitting in the bed and had a Dexcom Stelo device on him. And I looked at this patient and I said, I don't think you have diabetes. Maybe I missed it. And he didn't. Turns out he saw a commercial on TV and essentially went and bought this device over the counter. But we were having conversations about his blood sugars, which I really couldn't tell if they were real or not real. But then we had to have a serious sort of decision about, should we monitor this patient's glucose because he's getting values that seem to be out of range. How do you counsel patients like that and when they use these for lifestyle largely, as opposed to sort of really a real need? And then I'm really speaking to the primary care physicians in the audience because I'm sure they're seeing this as well in their clinics.
Yeah, I think this is one of those situations where, like, is it really appropriate to have all of these devices out there and people monitoring who maybe don't need it, and especially before we have any kind of information about what we're looking for. And so I think we're going to see this more and more because, you know, the availability of these over-the-counter or direct-to-consumer, because you really can't go to a pharmacy and pick them up. You have to order them online. So they're direct-to-consumer, but we call them over-the-counter. And I think that it's really great when people take an interest, you know, in their health, of course, and explaining kind of the limitations of these devices, especially when we're using them in people without diabetes. I think, you know, one of the potential uses is, you know, stress hyperglycemia is hugely common in the hospital setting. And so we tend to see it a lot in patients with prediabetes, but also a lot of people who have no history or no known hyperglycemia. And so I think it could be useful, but I think there's still a lot. So for example, the Stelo is approved for use in individuals with type 2 diabetes, not really for people without diabetes. So lots of limitations to these.
And just to close the loop, we actually saw incredible discrepancies between the readings they were getting and the readings we were getting. So,
accuracy is the issue.
Questions from the audience? Oh, there's one over there.
Thanks. Great talk and real informative. So we've been sort of battling, so switching back to the inpatient questions here, and then, you know, in the ICU, you know, we converted to tight glucose control after the Vandenberg papers, and then decided, you know, with the nice sugar, maybe we're actually hurting people, or her second study, and then sugar, and then so we backed off, and we sort of now let them run, you know, still try to keep control, realizing that hyperglycemia in the hospital setting is a bad thing, especially in critical illness, but we'll let them go to 180. It looked to me like on that study that you guys just tried to run, you still would think 180 is high and 180 is you know, not your goal. You try to get them down to 130, but seem like having trouble getting buy-in through that. I guess two parts of the question. One, like how much problem do you think it is that we let people in the hospital go to 180 in our ICU setting? Or is it, you know, again, these are mostly, you know, there's a lot of reasons their sugars are up, steroids, things along those lines. Is it not that big of a deal? Should we be honing in on that more, realizing, you know, these type of legs are better? And then I guess the question is like, why the technology seems to exist, you know, to dial this in. And certainly I can understand where hospitals wouldn't want multiple different monitors coming in, but it seems like a hospital system, for example, could adopt like one, if the patient comes into the hospital, we use one type, we train everyone how to use it, we get the data effectively, we dial in the glucose in that reason, as opposed to sort of using whatever monitor they bought off the internet or something along those lines.
I think, so your first question, I think, is about ICU targets in the ICU.
That 180, is that okay? Or should we really be striving to get to like 130 that you guys tried to do? Or
yeah, and the 130 that we were trying to go for was not in the ICU setting, just to be clear. So I think that it depends on when that 180 was. So is that, you know, fasting, or is that postprandial? So if it's postprandial, 180 is totally fine. So if someone is on tube feeding, someone's on TPN, 180 is actually probably okay. But if someone is fasting, we know that their blood sugars are going to go up by at least 30 to 50 milligrams per deciliter. So then starting at 180 is going to bring you to 220, 250. And so I think that's one. I think that actually it's a much more nuanced question. So not all patients in the ICU are the same. And so patients who have stress hyperglycemia versus patients who have existing diabetes, I think they're actually pretty different populations. So almost like, I think of it now when I'm starting to look at the data, almost like ischemic preconditioning, so with the heart. So people who have diabetes are actually relatively protected against some of the problems with hyperglycemia in the hospital setting, it seems. And then people with stress hyperglycemia, maybe not so much, and maybe we need to be targeting tighter targets. And so I think there's a lot more work that needs to be done there, so it's a little hard to say, but what we do know is that post-surgical patients need tight control. So really, but the medical ICU patients, maybe that's a different population, and maybe 180 could be okay depending on if it's postprandial or fasting. And then the second question of, you know, what do we do about technology in the hospital? I would love for us to be able to integrate CGM in the hospital. So I'd love to be able to integrate it. And I think that there are some places that already do it. So for example, the Stanford Hospital, but they're one out of thousands of hospitals. And so it's still we're still in pretty early stages. And there's a lot that needs to be done, like validating those those values besides trying to integrate the information into the EMR. And then, of course, I think one of the biggest problems is what do you do with those data? So if you actually have it there, who is responsible for watching it? It's not like, maybe right now for telemetry, we have someone who can be watching the monitors, but we don't have someone watching those glucoses.
Cecilia, I have a question. I'm assuming pumps and CGMs are going to go up in the type 2 population, which is likely going to be managed by primary care. What does having access to this data do to the workload of primary care outside of encounters that they are seeing their patients every 3 or 6 months? Assuming that goes up, how do we manage that in this very RVU-driven world that we're in?
I think that is a terrific question. I think that we actually need to figure out some new models. And so there are some models where maybe some of that interpretation is done by specialists. So that's maybe one model. But another model is being able to do it in a way that actually integrates with that workflow. But I agree. I saw a recent publication on the workload of GLP-1s being added to primary care practices, because it is a ton of work to get people on GLP-1s and to have them stay on the GLP-1s and to navigate the different types or the different choices. And so it's a huge amount of work. So when you add that on to an already overfull plate for primary care, it's huge. And so I think there's a lot that we need to work on there. But there are groups that are working on it. So for example, there's a group from Penn that has published recently on kind of their new model of care to be able to integrate the workflow for diabetes technologies in their practice.
Dr. Long, we are at time. Thank you for a wonderful talk today.
Yeah, thank you for your attention.